Welcome to ReviseMED. I'm Dr. Rahul Vijayan. Today we will discuss about how you can approach hypokalemia with these. So let's get into the topic. In this session, we will be discussing hypokalemia in the following headings. So we will look into the definition of hypokalemia, etiology of hypokalemia, and stepwise approach, and we will end the session with a bonus question. So what is the definition of hypokalemia? Hypokalemia is defined as serum potassium concentration less than 3.5 milliequivalent per liter. So etiologies of the hypokalemia can be classified as the following: pseudo-hypokalemia, hypokalemia due to intracellular shift, non-renal loss, renal loss, and inadequate intake, of which the most important etiology is the renal loss. That is, pseudo-hypokalemia occurs in AML because of the increased WBC. Potassium will be taken up to the WBCs, leading to low serum potassium levels. Hypokalemia due to intracellular shift occurs in the cases of insulin and beta agonists. Non-renal losses in case of laxative use, diarrhea, vomiting, nasogastric suction. Renal loss can be due to medications, especially diuretics, hypomagnesemia, syndromes such as Bartter-Gitelman, reproximal and distal RTA, and endocrine conditions like primary and secondary hyperaldosteronism, Cushing syndrome, congenital adrenal hyperplasia, renin secreting tumors. So these are the etiologies. So now we will go to the stepwise approach towards the hypokalemia. We already discussed that serum potassium less than 3.5 milliequivalent is defined as hypokalemia. So any patient coming with hypokalemia, first we have to rule out hypomagnesemia, check the serum magnesium levels. So once we have done that, next the physician's main job is to determine whether the hypokalemia is occurring due to renal loss or non-renal loss. For that, you have to do 24-hour potassium or potassium creatinine ratio. If the 24-hour potassium is less than 30 milliequivalent or urine potassium creatinine ratio is less than 1.5 millimole per millimole, then the cause is non-renal loss. Can include GA loss, especially diarrhea, vomiting, and nasogastric sectioning, intracellular potassium shift, insulin, salbutamol, and all. So, if the 24-hour urine potassium is more than 30 milliequivalent or urine potassium creatinine ratio is more than 1.5 millimole per millimole, then it is renal loss. This equation is if you are planning to use all units in SI unit. If you are using the creatinine in gram, then the ratio is 13. If it is more than 13, urine potassium creatinine ratio more than 13, then it is renal loss. So once you diagnose that patient is having renal loss, next step is to check the BP. If the patient is having normal BP or whether they are having high BP. If the patient is having normal BP, then you have to do bicarbonate level. If the bicarbonate level is low, then the diagnosis is or differential is renal tubular acidosis. If they are having normal or high bicarbonate level, you have to do urine chloride level. If the urine chloride level is less than 10 milliequivalent per day, then the differentials are vomiting and chloride diarrhea, because the lost chloride in the body through vomiting or diarrhea is compensated by the increased reabsorption of chloride through the kidneys, leading to very low chloride level in the urine. If the patient is having high bicarbonate level or a normal bicarbonate level with urine chloride more than 10 milliequivalent per day, the differentials are diuretic usage, low magnesium level, Bartter syndrome, and Gitelman syndrome. That's the approach towards if they are having renal loss of hypokalemia with normal BP. So now we are going to look the renal loss of hypokalemia with high BP cases. In that case, check plasma renin activity as well as aldosterone activity levels. If the patient is having high plasma renin activity with high aldosterone levels, the differentials are malignant hypertension, renovascular hypertension, and renin secreting tumor. If they are having low plasma renin activity with high aldosterone level, the differential is primary aldosteronism, because here The high aldosterone level acts as a negative feedback for the plasma renin, leading to low plasma renin. If the patient is having both low plasma renin activity as well as low aldosteronism, that means there is something else doing the activity of the aldosterone. It occurs in case of Cushing syndrome, congenital adrenal hyperplasia, and Liddle syndrome. Now we will summarize the approach towards the hypokalemia. So this is the summary. This is a simple summary. So as a physician, you should always remember the summary. First, our job is to find out the cause, whether it's a renal loss or a non-renal loss. If it's a renal loss, check the BP of the patient. If the patient is having normal BP, check the bicarbonate level. If it is low, the diagnosis or differential is renal tubular acidosis. If the bicarbonate level is high or normal, you have to check the urine chloride level. If the urine chloride level is less than 10 milliequivalent per day, then the differential will be vomiting or chloride diarrhea. If the urine chloride level is more than 10 milliequivalent per day, then the differential is diuretic usage, low magnesium, water, or Gitelman syndrome. If the patient is having renal loss or hypokalemia with high BP, you have to check the plasma renin as well as aldosterone levels. Now coming to the bonus question. How you can differentiate water and Gitelman syndrome, which is causing the hypokalemia? With this question, we will end this session. If you know the answer, you comment below. We will see the answer of this question in the next session. So, bye.